So unfortunately, many patients relapse with hematologic malignancies after allotransplant, and the currently available treatment options are clearly suboptimal. So we started a study a few years ago now using ipilimumab to block CTLA-4 to try to harness the power of the graft versus tumor effect to kill cancer cells, and this is applicable to any hematologic malignancy. In our initial study, we found responses both in lymphoid malignancies and myeloid malignancies. And at this ASH meeting in an oral presentation, I'll be updating those original data to show that we've shown a median overall survival of 28 months for our patients treated with ipilimumab at 10 milligrams per kilogram. This compares favorably with the median survival of about 6 months historically with patients in this situation. In this meeting, I'll also present for the first time data on a lower dose of ipilimumab, which did not seem to make a big difference in terms of the balance of safety and efficacy. And very excitingly, I'll also present data on using the PD-1 blocking antibody nivolumab for this same patient population. We've recently seen some reports in the literature of retrospective studies suggesting that nivolumab may be quite toxic for this population. Our study is the first prospective data of nivolumab for post-allo relapse in a clinical trial, and we have found some toxicity at the 1 milligram per kilogram dose. So at the 0.5 milligram per kilogram dose, we are actually seeing better tolerability, and we've seen some responses primarily in lymphoid malignancies. This is an ongoing study, and these are the first data that we're presenting. And we're soon going to be opening an expansion cohort to really try to see if there's efficacy of the nivolumab approach in the post-allo relapse setting.